So as I was saying, yes. I have one of those early morning brain farts where I'm I don't remember why I walked in. I walked back home.
Absolutely, I can. I get it. Good afternoon, everyone. Good afternoon. So, I understand you guys have midterms coming up. I understand that stress level is rising, not so gradually. This is going to be our last lecture before our first midterm. Hooray! So what we're going to do is, like I said on Canvas, we've got a couple things to run through. We're going to run through the sciatic notches and sciatic foramen. We're going to run through blood supply of the pelvis. We're going to run through lumbosacral plexus, okay? After that, I have 5-6 questions ready on a Kahoot just to get you guys kind of geared back up for doing test questions with me, okay? All right, so like we talked about last time, we have these great little sciatic notches and these great little ischial spines and all these tuberosities and all this great stuff, right? And like we talked about, the sacrospinous ligament and the sacrotuberous ligament. Remember that sacrospinous ligament is the ligament that goes more horizontal or in the transverse plane. Sacrotuberous ligament is going to be oriented more in a vertical plane. Those ligaments are going to section off and become key landmarks for different foramen, okay? And a couple different foramen that we're going to have is something called the greater sciatic foramen. Okay, so I'm going to draw kind of this in because we're going to see this. So I have something called the greater sciatic foramen. So the greater sciatic foramen is going to be this large opening. Okay? You kind of imagine it being this large opening. Now, the greater sciatic foramen is going to have a key muscle, a muscle that we have not talked about yet. We're going to introduce it here, and then we're going to jump into it in the next section much more in depth. It's a muscle that commonly you're going to hear in the clinic. Lots of people have problems with it, and it's going to be something called the piriformis muscle. Did I just get a yeah for the piriformis muscle? I gotta say, this is my third time teaching that. That's the first time I've ever got a yeah for the piriformis muscle. It does. It really, really does. This is going to be my piriformis. Now, what we're going to see is that piriformis is going to originate off the anterior portion of the sacrum. Okay? So it is a pelvic muscle. It is in the pelvic cavity. But what I'm going to see is that my piriformis is going to insert on my hip. It's going to insert on my femur. So it's going to have action across the hip joint. And like I said, we're going to get into that much more in depth when we cover the hip. In terms of this section of material, the piriformis is going to be a landmark. So the area that is above or superior to the piriformis is going to be called the suprapiriform space. So this area here is going to be the suprapiriform space. Bet you guys can't guess what the section inferior is going to be called. That's right. It's going to be called the infrapiriform space. Now, remember that this is all still the greater sciatic foramen. What I'm going to see, and this is going to be very key, not only in this unit, but especially when we start getting into the hip and the muscles like gluteus maximus and gluteus medius and gluteus minimus and all these fantastic, like this is why we came to PT school muscles, right? That's kind of the nice thing about the next section. It's like, yeah, I mean, we're going to talk about quads and all this great stuff, right? I'm going to have certain contents that are going to be named based on their relation or their position to the piriformis. One of those is going to be the superior gluteal nerve artery vein. And it's going to come out in a nice big neurovascular bundle. Okay, so we've kind of already encountered those at different spots around the human body where we see the nerve, the artery, and the vein all kind of running together. Superior gluteal artery, nerve, and vein are named based on their position versus the piriformis, or in relation to the piriformis. The infrapiriform space is going to have all sorts of stuff come out of it. In fact, the infrapiriform space is a lot bigger than the suprapiriform space. So here we go. Here's what's going to come out of my infrapiriform space. Again, we're going to put in some very familiar words here. Sciatic nerve, which we're going to learn is not actually a nerve. It's actually two nerves bundled. We're going to have another one called the pudendal nerve. And I'm going to put a little asterisk next to the pudendal nerve, because the pudendal nerve is a tricky little bugger. The pudendal nerve, believe it or not, exits the greater sciatic foramen, and then because it's a tricky little bugger, it then loops around and enters the pelvis again through the lesser sciatic foramen. Okay, so I'll say that again. The pudendal nerve exits the pelvis through the greater sciatic foramen, but then it loops around and goes right back into the pelvis because the pudendal nerve is what's going to innervate my perineum. Okay, that's going to innervate a lot of those reproductive sexual structures that I have. So pudendal nerve exits greater sciatic foramen in the infra-piriform space, wraps back around, and enters the pelvis again through the lesser sciatic foramen. The other things I'm going to have here, again, these are going to be named based on their relation to the piriformis. Inferior gluteal nerve, artery, and vein. I'm also going to see the posterior femoral cutaneous nerve. And then in the next section, we're going to start talking about muscles that are deep to gluteus maximus. Okay, the official name for them is going to be the 6 deep lateral rotators. The unofficial name for them, and this is specific to this program, are the P-go-go Qs. And that's not going to make any sense right now. You're going to say, what in the world are you talking about? Next week, when we go over the hips, start going over these muscles, you're going to go, heck yeah, P-go-go Qs, got it. That sounds ridiculous, right? But it's going to make sense. P-go-go Q. P-go-go Q. Yep. And literally, the P-go-go Qs, that's literally what tells you the 6 deep lateral rotators from superior all the way down to inferior. So a couple of those muscles are going to be the obturator internus. So the nerve to obturator internus. Run out of room here. And the nerve to quadratus femoris. Note, please, that quadratus femoris is not quadriceps femoris. Those are 2 totally different muscles. Quadriceps femoris is going to be that big, huge leg press muscle that comes off the front of my thigh. 4 heads. Quadratus femoris is going to be a tiny little square-shaped muscle that's quadrilateral. That is going to be my most inferior lateral rotator. And when you guys dissect it, it literally pops right out. It is this tiny little square. So in my infra-piriform space, remember, we're still in the greater sciatic foramen. Sciatic nerve, pudendal nerve, inferior gluteal artery nerve vein, posterior femoral cutaneous nerve, and the nerves to obturator internus, and the nerve to quadratus femoris. Okay, so that's going to come out of my greater sciatic foramen. The big ones, and this will really trip you guys up on test questions, trip you guys up on cadaver lab, things like that, especially when we start getting into the hip. Superior nerve artery vein, superior gluteal nerve artery vein, and inferior gluteal nerve artery vein tend to give students a lot of problems, because what we're going to see is that not only are they going to be named in relation to the piriformis, but they're also going to be branches off the internal iliac artery as well, okay, in terms of the arterial flow. So we'll get to that in a little bit. Any questions on this? Everybody good? Everybody good with the picture? Okay. So in terms of the lesser sciatic foramen, the lesser sciatic foramen is going to be a lot easier, because we're not going to have this big old piriformis getting in the way. So there's no supra or infra spaces. But there's a lot that comes out of the lesser sciatic foramen. There is a lot. What is going on with my pen? All right, so the lesser sciatic foramen. Here's what exits the pelvis in the lesser sciatic foramen. We're going to have something called the internal pudendal, and this is not the pudendal, this is another branch off the pudendal, artery and vein. Okay, I'm going to put a big asterisk here because I'm going to put the pudendal nerve. Remember what I just said. Pudendal nerve is going to enter the pelvis through the lesser sciatic foramen. Okay, and this is where things get tricky. Pudendal nerve exits out of the greater sciatic foramen, enters through the lesser sciatic foramen. Remember, it wraps around. The obturator, I misspelled that. Internus tendon, and that's going to be really key because the obturator internus tendon is going to be a key landmark for our pelvic floor muscles. Okay, so on obturator internus, and this is going to be another really weird thing about the hip and the gluteal region. Obturator internus is going to be named based on its relation to the obturator foramen. Okay, do you guys remember what the obturator foramen is? That big hole that's sitting in the pubis where all those obturator vessels and nerves come through? Literally, the way it works is obturator internus rides on the internal side of the obturator foramen. Obturator externus rides on the external portion. Okay? So obturator internus tendon is going to exit the lesser sciatic foramen because it has to kind of come through the gluteal region and get to the obturator foramen. The other one is kind of weird, and I know we just wrote this down. The nerve to obturator internus, because it has to wrap around as well. And it's going to do kind of the same thing the pudendal nerve does. Okay, so those are the big contents of the greater and lesser sciatic foramens.
So the nerve to obturator internus wraps around.
It wraps around and goes back in, just like
So it goes,
pudendal nerve.
it goes out of the lesser or goes
Out the greater
up?
into the lesser. Everybody good with the picture? Is anybody not good with the picture? That's not really a picture, but bad writing. Yeah, no picture, no problem with the picture because there isn't one. Come on, right? It's terrible. All right, so next thing we're going to jump into here is going to be the pelvic floor. So without any further ado, that's going really slow. Why am I going so slow? So what we're going to draw is we're actually going to draw a top-down view. Okay, so what I want you guys to imagine is you take the pelvis, and I'm going to turn it kind of like I'm looking into the pelvic cavity or looking into a bowl. Okay, that's how we're going to draw this. The closest picture to all this is going to be this guy down here. Okay, but I wanted to provide this picture as well. That one's straight out of Gray's. That is a Hemi Pelvis. So basically they just took one ilium off, and you can see down into the pelvis. So you can get a little bit of context here. All right, so what we're going to do is we're going to draw in our pubic rami and our pubic symphysis. So here's my pubic symphysis. Whoa. And then I'm going to draw this big ring because that's going to represent my pelvic ring. Down here at the very bottom, what I'm going to do is I'm going to draw a triangle. That triangle is going to represent my sacrum. And then I'm going to draw another little triangle, quote, on top of it. And that's going to represent my coccyx. And these are all very important landmarks here because what we're going to see is that I'm going to have specific muscles that are going to come off of and attach to my sacrum, and specific muscles are going to attach directly into my coccyx. And they're going to be named based on where they attach. I'm also going to draw in two Obturator Foramen, and this is where this gets important, that fascia. Okay, so this is an Obturator Foramen with fascia of Obturator Internus. Then the other things I'm going to draw in here are these two little triangles. And those are going to be ischial spines. Okay, so a lot of terms that we've already encountered, a lot of terms we've already been familiar with. But what we're going to see is that I'm going to have a lot of my pelvic floor muscles that are going to use these already existing anchor points for attachment. The other thing I'm going to draw in here is something called a tendinous arch. Okay, so there's going to be I'm going to draw it in a different color. There's going to be a large kind of tendinous arch. And a tendinous arch, it's part of Obturator Internus. And it also provides just another anchor point for a lot of these muscles to attach to.
Is it just connective tissue?
Just tendon. Yep. Now the other thing I'm going to draw in here, if we're looking at a top-down view, is I need to draw in my different apertures through the pelvic floor. Now this is what makes the pelvic floor very unique. Remember, the pelvic floor, or what's commonly known as the pelvic diaphragm, is going to be a big sling of muscles, but they're going to have holes in them, right? I'm going to have a vaginal hole for the female anatomy. I'm going to have a hole for the urethra and spermatic cord if I'm a male. I'm going to have a hole for rectum, okay? So I'm going to draw in the female anatomy, but realize that both male and female anatomy is going to have all of these same muscles, okay? And that's one of the big pushes right now in PT, especially pelvic floor PT, is pelvic floor PT for males, okay? Because for years and years and years, it was exclusively for females, and there's a lot more males accessing it now. So first hole I'm going to draw in here is going to be the urethra. I don't know why it's going away, but it is today. So urethra. The second one I'm going to draw in is going to be representative of the vaginal hole. And then I'm going to draw in the rectum. Okay, so I'm going to draw a little R here for rectum, V for vagina, and U for urethra. Now the first muscle we're going to draw in is going to provide this really nice, almost sling-like attachment here. So it comes right off of the pubic rami, and it comes around and almost envelops. I'm going to kind of draw that in a little bit so you guys can see. It almost slings right around the rectum. I never said my coloring was better than my drawing. So this red muscle here is going to be called Pubo Rectalis. Moving posterior, coming off of this tendonous arch, obturator fascia, and then diving directly down to the coccyx. This is going to have a right and left side. And it kind of comes around as well. This guy in green here is going to be called Pubo Coccygeus. Oh. It comes off of the obturator, like the fascia of obturator internus and the pubis bone. Right, so that's why it's called Pubo Coccygeus. A good question. The other one that I'm going to see back here is going to come more off the ilium and a little bit of the ischial spine. So it's actually going to come off kind of this way. And this one's going to be called Ilio Coccygeus. Okay. Now, before we draw anything else, we're going to discuss a muscle that you're going to see in the literature, because this muscle is a very common name. You'll see it a lot, but it's actually three muscles hooked together. You're going to hear a term called levator ani. Says what it does what it says. It elevates my anus, right? AKA, this is your midterm muscle, right? When you see that midterm, whoa, it's time to take a test. Right? Yep, that's my puffer muscle. Right? I thought you guys would get a kick out of it. What's that?
That's the more the final.
Yeah, okay, yeah. Well, let's face it, by finals in this program, it's pretty well conditioned, right?
That's what we've just given up.
Yeah,
These classes.
that would be third year. NPTE, yeah, it's overtrained. We're having tendinopathies in it and all sorts of stuff, right? So when I mention levator ani, What I'm really referring to is the combination of Pubo Rectalis, Pubo Coccygeus, and Ilio Coccygeus. And the reason is, when they did the original dissections, they said, oh, that's just one big muscle. Later, when more detailed techniques came out and more technology came out, they kind of realized that's actually three different muscles there. So Pubo Rectalis, Pubo Coccygeus, and Ilio Coccygeus is levator ani, okay? So if I take these three muscles together, and I'm going to circle them, those three muscles as a group is called levator ani, okay? I want to make sure we really make that distinction, because what we're going to see here is I'm going to have levator ani muscles. I'm going to add in another muscle that's going to be considered part of the pelvic diaphragm or pelvic floor. And then I'm going to add in another muscle that's not part of the levator ani or part of the pelvic diaphragm. Okay, so that's why I want to take a little bit of time and make sure you guys understand this. The next one that I'm going to draw in is going to be Coccygeus. Coccygeus is going to come off the ischial spine, and it's going to go straight to the coccyx. Okay, no big deal. This is going to be Coccygeus. Now, when I mentioned Pubo Rectalis, Pubo Coccygeus, Ilio Coccygeus, and Coccygeus, all four of those guys together is what's going to be my pelvic diaphragm. Okay, so I want to make sure we really understand that. The only other muscle that I'm going to see back here literally is going to be just there because it's there. And that one's going to come off the anterior sacrum. It's going to travel out to the greater trochanter of the femur. We've already kind of discussed this one. And that's piriformis. Piriformis, not part of the pelvic diaphragm. Piriformis, not part of the levator ani. Piriformis gets all its own credit on its own. Okay? But in terms of dissection, in terms of when you guys are actually looking inside that bowl, that is the pelvis, you guys are going to see these. And they pop out pretty quick, and they pop out pretty clear. So I want you to understand that piriformis is not part of the pelvic diaphragm. When I refer to the pelvic diaphragm, that's referring to that sling of muscles that are holding things like my bladder up. Okay? So it's just those muscles in the bottom of that pelvic ring. Yes?
Is the tendonous arch in front of all these, or behind all of them, or on top or under? Or...
Good question. That's the tendonous arch right there. Okay, so if I'm looking down into the pelvis, this tendonous arch, it just kind of this little piece that comes off of all this stuff, right? And basically, it's, what's a good example here? It doesn't really attach much to much. It's just kind of there, kind of comes off the ischial spine, and it provides just this nice connection for everything to attach to. Does that make sense? That picture, that top picture is straight out of Gray's, and obviously you'll get to see a much bigger version of it. All right, any questions? Any questions? Mm-hmm. This one's in grays, this one's also in netters. All right, now, we okay, guys? Okay, sweet. All right, big round of applause. This is the last plexus that we're going to cover this semester. Right? So we're going to knock both plexi out of the way early. We're not going to cover any more plexi. Okay, just like we did last semester, we got them out of the way fairly early as well. This is our sacral plexus. Okay, now sacral plexus, if you look at this picture, looks like it is absolutely terrible, right? It looks like it's all over the place. Sacral plexus in reality is really not that bad. Okay, so I just want to bring that out there. That's really not that bad. So what I'm going to have with my sacral plexus is I'm going to have an anterior division and I'm going to have a posterior division. I don't know why it's doing that. So anterior division is going to be in black. Posterior division is going to be in red. My roots are going to come down L4 down to S4. Okay, so I'm going to have L4, L5, S1, S2, S3, S4. These are all going to have a lot of similar branching off of them, okay? So what I'm going to see here is I'm going to have these big branches coming off. L4, L5, S1, S2 are all going to kind of collect down into a really big nerve called my common fibula. Depending on where you did anatomy for undergrad or high school or whatever, fibular, and we're going to get into this much later on in the semester, fibular equals peroneal. Okay, so if you guys are familiar with the peroneal nerve, anatomy is moving away from using the Greek words. Peroneal is Greek, Latin is fibular, or fibular is Latin. Okay, so L4, L5, S1, S2, all going to come down to form the common fibular nerve. Okay? Off the anterior branch here, this is going to be another one of our big honking nerves here. L4, L5, S1, S2, and S3 are all going to come together, and they're going to form something called the tibial nerve. That was really bad. Okay, so my tibial nerve and my common fibular nerve are going to be important because my common fibular nerve plus my tibial nerve is going to equal my sciatic nerve. So remember at the very beginning of class I said that the sciatic nerve is not really a nerve. The sciatic nerve is really two nerves that are bound together by a really, really thin piece of connective tissue, a very thin sheet. In fact, when I was in PT school doing my cadaver dissection, I took that nerve, I took that sciatic nerve, and I did this and pulled it apart and ripped it all the way up to the gluteus, which did not make my professor very happy. Just saying. Don't repeat my mistakes. But that's how thin, you guys will see it. It literally is a very, very thin sheet holding those nerves together. So the sciatic nerve now is not really a nerve. It's two nerves hooked together. Yeah.
Did you say that the tibial was anterior or posterior?
The tibial? The tibial is anterior. Yep. Confibular is posterior. I drew it backwards. I do that. Okay, so my red is going to be my anterior. Okay, I got the pendulum right. Something good KO on it. My black is my posterior. Fair? Everybody good?
So if someone's sciatic pain, is it because again, or is it with the sciatic?
I'm not able to hear you. I'm sorry. Can you speak louder?
If someone has like sciatic pain, is that more of like sciatic again, or actually your common tibial and tibial?
So what we're going to learn is sciatic pain is the distribution down the quote sciatic nerve. It's definitely not IT band. But what it is, it's going to be either tibial or common fibular or both. Okay. So other branches I'm going to have coming off here. The superior gluteal artery is going to come off of L4 to S1. Okay, so another branch off of all this. L4, L5, S1 is going to branch out to be my superior gluteal artery.
Posterior aspect.
Posterior aspect, yep. My inferior gluteal artery is going to come off of L5, S1, and S2. Okay, again, posterior aspect. My nerve to piriformis, because piriformis gets its own nerve, comes off of S1 and S2. And then for right now, we're going to cover a lot more of these later on because we're going to revisit the sacral plexus. For right now, my pudendal nerve is going to come off the anterior branch. And that's going to come off S2, S3, and S4. So that's going to be my pudendal. And then my pelvic splanchnics, and remember that is parasympathetic innervation. That's going to come off of S2, S3, and S4. Okay? We're going to cover this again when we start covering the hip and gluteal region because we're going to have a lot of muscles that these nerves are going to go to that we haven't even covered yet. So, in my opinion, it doesn't make much sense to cover it now. Okay? So, that is like the very, very basics of the sacral plexus. Pelvic splanchnic length is S2, S3, and S4. Yep. Okay. Everybody good with the picture? Sure. Remember, I'm also recording the lectures. That's why I'm wearing this funky headset, even though all you guys are in the classroom. That's fine. Now, again, like we did last semester, please don't abuse that. Okay, that's all I'm going to ask. Well, yeah. All right, everybody good with the picture? All right, so blood supply of the pelvis. Now, here's what I'm going to tell you. If you look at Gray's page, was it like 489, something like that? There's, I'm sorry?
89.
Okay, so 489, 491. They have essentially, I won't even say essentially, I took these two pictures right out of there. They got this picture, and they got this picture, okay? What I will tell you is that I'm not going to draw in all the little tiny structures because the picture gets really, really messy. What we're going to draw out is a very basic schematic of, hey, basically, here's what branches off of everything else, okay? So remember that as my aorta comes down at about the sacral level, it's going to split into my two common iliac arteries. When I draw this out, I'm only going to draw one of those common iliac arteries. So please recognize this is happening on my left side and my right side. So I'm going to have my common iliac artery. It's going to branch into the external iliac and an internal iliac. The external one is super duper easy, so we're going to do that one first. My external iliac is going to give off just a couple branches. It's going to give off something called the inferior epigastric. We kind of talked about that one. And it's also going to give off something called the deep circumflex iliac artery. Now, once the external iliac artery gives off those branches, I'm going to draw a little dotted line in here. And that little dotted line is going to be the inguinal canal. Once that external iliac artery travels distal to the inguinal canal, or the inguinal ligament, it's going to change names, right? Like a lot of the roads around here. It's going to change names to femoral artery. So understand that the femoral artery is simply the distal continuation of the external iliac artery. That's all it is, okay? My internal iliac artery is going to have two different divisions. I'm going to draw in two different colors. It's going to have an anterior division and it's going to have a posterior division. The posterior division is going to give off the iliolumbar artery. And it's going to give off, I'm going to draw these kind of short, a lot of little arteries called the lateral sacral arteries. The internal iliac artery will then continue on, and that's going to end up exiting the pelvis as the superior gluteal artery. Now remember, with that superior gluteal artery, that's going to be that artery that exits the greater sciatic foramen supra-piriform. Right, because it's named superior gluteal artery based on its position in reference to the piriformis. Now the anterior division, I'm just going to warn you, that's where all the action is. The anterior division is going to give off a whole bunch of arteries. It's going to give off something called my umbilical artery. Off of the umbilical artery, I'm going to see a branch called the superior vesicle artery. I'm also going to see directly off of the anterior branch my obturator artery. Obturator artery is going to be named based on the fact that it's going to exit through the obturator foramen and what's called the obturator canal. It's going to supply the medial thigh. Okay, so what we're going to see, we're going to start seeing a lot of patterns again, right? So obturator nerve, obturator artery, medial thigh, supplying my adductors. Okay, muscles like gracilis, adductor magnus, adductor brevis, adductor, longus, guys like that. After all this happens, after I get off my obturator artery, I'm going to give this one two different names, okay? Because in the male, so we're going to write male, this is called the inferior vesicle artery. And the female, this is the vaginal artery. Okay, so I'm going to kind of case those in, even though it's one artery. But it just goes by two different names because everything in anatomy is based on what it's called and where it is. My anterior division then is going to kind of split in two different directions. It's going to split into something called middle rectal. And then the other way it splits, it's going to give off the inferior gluteal and the internal pudendal. Okay, so big things to remember here. Okay, number one, my superior gluteal artery is a branch off the posterior division of the internal iliac artery. Inferior gluteal artery is a branch off the anterior division of the internal iliac artery. If I'm going to take a gamble on what pelvic or perineal structures are going to be supplied by blood, I'm going with the anterior branch of the internal iliac artery, right? Look at how many of those things come off of the anterior branch. The anterior branch is where, like I said, that's where all the action is. My posterior branch is going to send a lot of structures to the posterior pelvic wall. Lateral sacral branch comes off there, superior gluteal artery branch comes off there, iliolumbar branch, right? Think about where the structures are. They're all in the back. So a lot of times a little schematic like this can help because, again, midterm's coming up on Monday. You know, there's going to be questions like, hey, you have an occlusion here. What structures are going to be affected? Or, hey, you have an occlusion here. Where is the actual infarct? Okay? All right, any questions? Everybody looks thrilled. And I'm fully aware this is the weekend before Valentine's Day, and I apologize about that. You don't, oh, okay, well, I'm not sure how to respond to that. What's that? You don't have, okay, fair enough. Fair enough. All right, okay, so we got about 6 minutes left. If you guys want, we can do a couple of Kahoot questions. Okay. All right, let me sign into Kahoot really fast here. Hold on 1 second, just so I can share it. All right, you guys go. There we go. There's a little more creativity with the names. It is Valentine's. What can I say? I'm not even sure what that is. I'm not even going to ask what that is. All right, you ready to rock? Is everybody in? Anybody not in? All right, here we go. Small amount of blood is there to the posterior of the stomach. This part of the peritoneal cavity is the what? Oh, removing. I'm sorry. Is that better? Okay. Not a problem. lesser sac. It's posterior to the stomach, guys. Lesser sac. Retroperitoneal space is way back there. Way back there. So yeah, a right dominant heart is where the posterior interventricular artery is derived from the right coronary artery. Remember, we kind of talked about this way back, like first day of the semester, where the left coronary artery and right coronary artery kind of come together, that posterior interventricular artery. When the right coronary artery is the dominant side of blood flow, that's considered a right dominant heart. That leads to all sorts of fun stuff. And by fun stuff, I mean all sorts of different problems than a left dominant heart. Ooh. Guys, celiac trunk, foregut, midgut, or hindgut? Foregut. Which of those structures is a foregut structure? Sweden. It's okay. It's okay. You're going to get it right on the midterm. That's where we're going. Should be the superior aspect of the right kidney. So why is epinephrine called epinephrine? What's the basic unit of the kidney? The nephron. Ever see that connection? You like that? So then, think about what's the gland on top of the kidney? Adrenal gland. People say adrenal. It's the adrenal. It's on top of the kidney. Descending colon, left colic artery or left colic artery. Remember that left colic artery comes off the inferior mesenteric artery, okay? Remember how I talked about the pancreas is a super weird organ? Like part of it's intraperitoneal, part of it's retroperitoneal, part of it gets celiac trunk, blood flow, and then we have all those infra pancreatico-duodenal arteries that come off of the superior mesenteric, right? So pancreas is not a true foregut structure. It's kind of foregut, and it's kind of midgut, okay? All right, I know we're a couple minutes over. Thanks for extra time. Everybody have a very good weekend. Oh, yeah, we got to see one. Sorry. Most important thing. Nondescript. Trevor, I think you've won like every trivia session, haven't you? Or you're on close.
He's always a different.
This is like Fritz, right? It's not even a name anymore. It's just a symbol. All right. I'm sorry?